Thanks, and thanks everyone for joining tonight, or whereabouts, wherever you are. I think there's about 44 countries where vets have registered from for this webinar, so we're looking forward to it. And a brief introduction to FS Animal Health if you've never heard of us before, but you've seen this webinar. Our vision is to be the global leader in solving equine health challenges through advanced nutrition and therapy. And our whole mission is to enable horses to live healthier for longer. So we work in a few different countries. We access every country in Europe now, and also in America. We have a base in Florida. And the two main focuses that we have are Hestevard, which is the voice of authority in equine nutrition, which will enhance a horse's health and performance, and Haygain, which is the voice of authority in equine therapy. So tonight on the webinar, we have Emily Floyd. She is an RCVS recognised specialist in equine internal medicine and a diplomat of the American College of Veterinary Internal Medicine, and she is a member of the internal medicine team at Rossdale's. So without any further delay, Emily, it's over to you, and we are very much looking forward to this presentation.
Thanks, Bruce, very much, and thanks, Daniela, and thanks everyone for joining me. Right, so let me just share my screen. Okay. Right, Bruce, give me a thumbs up. Is that all okay? Yeah, perfect. Okay, welcome everybody, and thank you so much to everyone for joining us. Thanks so much to Bruce for inviting me to give this webinar tonight. It's a topic I feel pretty passionately about. It's a topic which there's a lot to discuss and there's quite a few challenges. So without further ado, this is what I plan to run us through tonight. So when we think about gastric ulcers, there's quite a few differences between adults and foals. So we're going to think for the first little bit about some of the risk factors. We're going to then touch briefly on the prevalence of ulcers and then get more into the practicalities of it. So clinical signs, diagnosis, treatment, and then prevention, which obviously is a big part of what we're hoping to aim for as equine vets. So to get started, when we're thinking about gastric ulcers, this is actually one of the areas where there are really a lot of differences between foals and adults. And it's really important that we understand some of those physiological differences because it really changes the way that we use medications, the way that we maybe approach the disease, the understanding of the risk factors. And I think this is one of those particular topics where actually, we know, don't we, that foals mature a lot over those first few weeks, and that we have to modify quite a lot of what we do. But this will change quite a bit over the first few weeks. We see those very specific things. Gastric ulcers is a slightly different syndrome in the baby foals that we see. Then we see perhaps a slightly different spectrum again in foals of 1 to 2 months of age. And then as we're getting to that older foal, perhaps by the time the foal gets closer to weaning, we're looking at a physiology which is quite similar to the adult. So if we start at the beginning, we think about the stomach. This is a stomach from, unfortunately, a foal that's had a gastric rupture. And you can see in that top left corner that there's a hole in the stomach at that junction of the margo and the margo plicatus. But fundamentally, the stomach anatomy is very similar to an adult horse. Obviously, the stomach is smaller and it will mature over time, but the anatomy is very similar. We have, squamous mucosa, we have glandular mucosa, and then we obviously have the pylorus into the outflow with the duodenum. And that, the size of it will change over time, the function of it will change over time, but it is very similar in appearance. So we know much more about the squamous mucosa of foals than we do the glandular mucosa, and there's quite a few studies which have looked at the histology and the anatomy of the gastric mucosa in foals. So this is quite a cool study they did where they looked at samples from the gastric mucosa in foals before term, so basically in fetuses, then to term foals, and then to foals over the first few weeks of life. And you can see that there's quite a lot of change that happens. So if you look between that top left picture, which was a fetus, to that term foal, you'll see that what we're getting is keratinization of that superficial layer of the squamous mucosa. And when we think about the role of the squamous mucosa, we know it's protective. And so as the foal gets older, that layer of superficial squamous cells gets thicker, which gives more protection. So if you compare that foal at term to the foal at 14 days, you can see there's quite a big change in the amount of sort of superficial epithelium. And again, you compare that to the two pictures at the bottom, you can see that progresses with time. And then that bottom right picture would be much more similar to what we'd see in an adult horse. And the interesting thing in this study was that they were also looking for signs of desquamation, which is loss of that superficial mucosa, which obviously is the precursor to gastric ulceration. And they were seeing that in this study from foals as young as 2 days of age. This is actually a picture of a foal, I think it was 18 days of age, and you can see this foal is already getting quite significant loss of the superficial squamous epithelium. So what else do we know about these really young foals? Well, firstly, their gastric pH is different, and that changes quite quickly and it reaches adult levels quite quickly. But if we're talking about these really young foals, they generally have a higher pH. So the pH is probably close to 4 in a newborn foal, and it will decrease to adult levels by the time the foal is probably sort of 3 to 5 days of age. There is a bit of variation in that. We'll come on to talking about the differences in sick foals, but certainly that is a difference. So it's important that when we're thinking about what drugs we're using to treat these things in those first couple of days of life, actually the foal's stomach is not as acid as it would be in an adult horse. We also see there's quite a lot of variation over the course of the day. So it's sort of like a rhythm in the foal that the pH of the stomach will change predominantly in response to milk ingestion. And when we think about what a normal foal does, they'll have periods of sleep, won't they? And then they'll get up and they'll nurse. And that milk has a really alkalinizing effect on the stomach. So this is a pH graph from a healthy foal. And you can see the pH is a bit closer to 4 that you would expect in an adult horse, but you can see it does fluctuate, and that's generally in relation to the foal's feeding. And again, if I show you this picture, this is a graph from a study when they were looking at medications. But what it really highlights quite nicely, this is a sick foal, and the little arrows indicate when the foal was being tube fed with milk. You can see what a profound effect the milk is having on the gastric pH. Actually, in this foal, the pH is quite high, and that's abnormal. Actually, that's a sign of illness in the foal. But actually, it shows you what a significant effect the milk has. And again, that's when we're thinking about treatment and prevention, this is a factor that we can really use to help us. So that's healthy foals. When we think about sick foals, then the take-home feature, especially in these baby foals again, is that the gastric pH is quite variable. And actually, it's really quite common to see in these ill foals in the first few days of life that they have an alkaline pH. That's definitely also true in foals that are premature, that they don't seem to be able to make that normal amount of acid, and they may be getting some reflux of small intestinal secretions. And so again, we're thinking about medication. There's no logical sense to trying to suppress acid because actually most of these foals will have an alkaline pH in the first place. So they're drugs which probably aren't that useful over the first few days. We'll go on to talk a bit at the end about perhaps the implication of this alkaline pH, and there's some suggestion that perhaps the pH, if you have a foal that has a really alkaline pH, that's it's not a good sign of prognosis. It's probably actually not the pH per se. It's probably a fact to the fact the stomach is not working properly. So it's more probably the fact that the gastric physiology is not working as it should, rather than the actual pH per se. So when we're thinking about these baby foals, what is probably the most important thing? And it's probably gastric perfusion. And we know with lots of studies that hyperperfusion is a real problem in terms of mortality in foals. And we translate that to thinking that poor gastric mucosal perfusion. This is a study which they actually use tonometry to measure gastric perfusion. And so that is possible, but we are recognizing that actually when we're getting gastric disease, it's probably part of a multi sort of organ problem in these young foals. And there's loads of studies, I won't go through them all, but documenting that association between perfusion problems and non-survival. These are just a couple of them looking at different markers of perfusion. We all love to measure lactate, and these papers, show there's an association between high lactate and non-survival. And I think that is, again, when we're looking at the gastric side of things, that association reflects the fact that we are, one of the risks for gastric disease in these young foals is that they are having not adequate gastric perfusion. So when we think about what we consider the classic risk factors for gastric ulcers in adult horses, then these would be the main factors that we think about. So we've talked already about things like the acid secretion. So in an adult horse, when we're thinking about squamous ulcers, we think about excess acid, we think about excess other compounds, things like pepsin, we think about reflux of bile acids. And then when we think about the protective effects, what are we thinking normally happens? Well, we're thinking about normal turnover of the lining of the stomach. We're thinking about having a really good mucosal blood flow. And then we're thinking about all those local factors. So things like bicarbonate production, the generation of that mucus layer, and things like prostaglandins. And certainly we know much less about these factors in foals than we do adult horses. But these are the things that we're thinking are still likely to be protective in foals. So coming back to this point, if we're thinking about the risk factors in the young neonate, most of those risk factors that we consider for adult horses probably aren't relevant. We know they're not making excess acid. Sure, they may be having some reflux, but they are not the main things. And in these critically ill foals, the main risk is probably hyperperfusion. So it's most likely the fact that you're having inadequate perfusion in the first place, also compounded by other things. So we're having lack of milk feeding and all the local protection that has. And again, the other thing that we're thinking about in these young foals is if they have a component of intestinal disease in general, that can increase the risk of gastric ulceration. So these more sort of general factors are things that we're thinking about. If we're thinking about trying to prevent ulcers in this age of foals, we're trying to treat it. These are the areas that we should be focusing on rather than acid suppressive medication. Whereas when we think about the older foal, we're starting to think about a lot more of the physiology that we would think about an adult horse. So excess exposure to acid becomes very relevant and all the other local factors. We may have some reflux. Decreased milk intake is certainly still very relevant, and we'll see that, as a general thing as the foals get older, but also in any sort of state of disease or stress. Diet obviously is really important, and we'll think a bit more about that. But when we think about the way that we deal with foals and the commercial way that we deal with them, we're starting to introduce quite high starch feed actually at quite an early age. That's not very physiologic. That can have a big role in terms of promoting acid exposure. Concurrent disease is really important. We'll focus on the main highlights of that, but concurrent problems, specifically things like enteritis, is a real risk factor for gastric ulcers. And then microbiome I've put here. There's no question that the microbiome is an important part of this, and that having a healthy microbiome will decrease the risk of gastric ulcers. There's some really great work going on at Surrey where they're looking at this in more detail, and I think we'll learn a lot more about this over the next couple of years. And then stress also becomes really relevant, and especially again when we're thinking about these, particularly these foals as they're getting close to weaning, there's huge stress factors involved with that. Social changes, diet changes, different stabling, different management routines, and that stress at that time point with the diet change can be a real risk factor for gastric ulcers. So we'll just run through those in a bit more detail. Start with diet because it tends to be the thing that we focus on, particularly when we're thinking about adult horses. And certainly this holds true as we get these foals, they're getting older. And there's a number of studies now looking at the incidence of gastric ulcers in weanlings and showing that, unsurprisingly, weanlings that have a higher grain diet have a higher risk of ulcers. I think what is surprising is when you think about the way that we feed these young stock in general, and obviously it depends on what sort of foals you're involved with, what sort of management system they're in. But actually, we supply an amazing amount of starch to these foals. So this is just a example of a general generic stud mix that you'll see, and you can see actually that the starch and sugar is actually still reasonably high. And so I think generally we are putting quite a lot of pressure on these foals with the diet that we're supplying them. Concurrent disease, this is a thing I'll keep coming back to, and I think this is probably, in my mind, the biggest risk factor for gastric ulcers in foals. And that is generally gastrointestinal disease being the most important. This study here is actually a post-mortem study, so it obviously is a slightly different subset of foals. It's foals that were post-mortem for a whole variety of reasons. They weren't grouped because of ulceration. So they looked at the prevalence of ulceration in foals that died for a whole variety of reasons. And what was a really strong finding in this study is that the foals that had gastrointestinal disease had a much higher incidence of gastric ulcers. And I think that's what we see in real life, that one of the biggest triggers for the generation of gastric ulcers in foals is having concurrent or previous gastrointestinal disease, usually diarrhea or enteritis. That can be any type of diarrhea. I don't think it really matters. I think the more severe the diarrhea or the more severe the inflammation in the intestinal tract, the more prone these foals are to getting gastric ulcers. I just mentioned rotavirus because there definitely seems to be a sort of maybe a specific thing about the way that rotavirus affects the intestines, which increases the prevalence of duodenal disease in foals. And it's certainly a very small percentage of foals. because we know that most foals will probably have exposure to rotavirus over those first few months. But most of the foals that will end up developing duodenal disease will have had fairly recent rotavirus infection. And we think that's because it infects the enterocytes, so the small intestine, the duodenum. And that presumably has some role. Some of those local factors are affected, but it's bigger than that. So foals that have enteritis with that intestinal inflammation, it seems to affect also their gastric physiology, and they are much more likely to get gastric ulcers. Stress, again, we know, and I think one of the reasons why ulcers become more prevalent in foals as they get close to weaning is because inherently there's more stress in their life. There's a number of studies looking at comparing cortisol as a marker of stress and the levels of gastric ulceration, but they're actually, showing that there's quite a high prevalence of ulceration in stress foals. This is a study that sort of blends the combination of stress and weaning, but showing this study was actually looking at different diet preparations, but showing that, pre-weaning, it's already quite a stressful time, high prevalence of foals, and 100% of foals in this particular study had gastric lesions after weaning. And so when we think about the number of changes that happens to these foals at this time, this is definitely one of the highest risk times in certainly a commercial foal's life. There's some quite interesting study now about weaning where we're looking at weaning a bit later, and that does seem to help reduce stress. The one other thing I just mentioned about stress, and again, this is probably a bit thoroughbred focused, and again, people around the different parts of the world, there will be different stresses, and some of your foals would be farmed a lot more extensively, but certainly in the world that I live in, we impose a lot of stress on foals. This is the sort of thing that we will do. This is a foal that's had a fetlock screw for an angular limb deformity to improve their conformation fundamentally for sales, but this is a sort of 3-month-old foal that's then having a surgical procedure under general anesthesia. Associated with that, they'll have to have medication, so likely some non-steroidals and some antimicrobials. And so we are imposing quite a lot of stress on these foals. That leads nicely onto non-steroidals, and we know again that non-steroidals induce gastric ulceration. These are quite old studies, but showing, in all these papers, there's definitely, clear evidence that when we're using non-steroidals, they induce ulceration in foals. And I would say that's much more significant than adult horses. If you look at all the non-steroidal studies in adult horses, certainly there is this, there is some increase in prevalence of gastric ulceration, but it's much more marked in foals. So it's certainly a side effect that we would worry much more about. So if we're having to use these drugs, and sometimes we do have to use these drugs for a variety of reasons, perhaps musculoskeletal disease or, conformational problems, other causes of pain, then we really do need to think about the side effects of it, and gastric ulcers being one of the big ones. So when we think about prevalence, the answer is it really depends on what population of foals you're treating and looking at, but actually some fairly good evidence suggesting that gastric ulcers are really quite prevalent in foals in general. So this scoping study that was done in the early 90s, about 50% of healthy foals. I showed you already that post-mortem study, that was about 22% of foals. I would think it's probably somewhere between those two, maybe a third of foals have some degree of gastric ulceration, but that when you start putting the pressure onto these foals, you really are very likely to cause gastric ulcers. So I think if you look at the different studies and you see what you experience in life, it can be up to, I say 100% of commercial foals, but what I mean by that is foals that are pushed into perhaps slightly early weaning, quite a high starch diet, if we're imposing all those stress factors. So moving on to the clinical signs of it. So, how do we recognize these foals? We know it's really prevalent. We're aware of all the risk factors. We're aware of the foals that we're particularly looking for the disease in, the foals that we consider being in the high risk group. These are what's considered the classic clinical signs of gastric ulcers. So bruxism, excessive chewing, excessive salivation, colic. People always talk about foals lying on their back. I mean, I don't think that, foals lying on their back with any form of colic, that certainly to me doesn't distinguish from gastric ulcers from another cause of colic. But these would be the classic clinical signs. I think the reality of these things is these are actually quite rare. So if you're seeing foals with these clinical signs, I'd say they're very likely to suggest that the foal has ulcers. But I would say the vast majority of foals with ulcers do not display these severe clinical signs. These, in my experience, would be much more common. These are the things that I think you would classically see. A foal that's just not quite 100%. So maybe slightly ill-thrifty, maybe a slightly poor hair coat, certainly slightly reduced growth. And that can be as subtle as, you can have a foal that's in front of you that looks perfectly healthy, perfectly well, has a nice coat, but when you compare their growth curve compared to the other cohorts, they may be slightly off the growth curve. And again, that may be the subtle sign that you see. I also put on here increased fibrinogen, but what I mean by that is that you're often seeing just signs of low grade inflammation in these foals. So perhaps it's a foal that you're examining because it's a bit thrifty, just not 100%, and you're running bloods as part of that, and you're just recognizing this low level chronic inflammation. And that may be partly driven by the ulcers, but it also may well be driven by the fact there's a concurrent low grade inflammatory disease in the foal, which is pushing you to have gastric ulcers. So these are the things I'd encourage you, if you're seeing these things, to really be thinking about the likelihood of ulcers in these foals. And then the saddest thing is that actually it's also really common just to identify no clinical signs in foals. And that becomes a real challenge when we get faced with this. This is a foal that's had a peracute gastric rupture. This is a foal that was perfectly healthy, was galloping around a paddock with its friends, and then is found dead in the morning. And that's one of the real challenges with this, and sort of differentiates us again from adult horses, where we do see this peracute gastric rupture in a foal that's shown no preceding signs of gastric ulcers. And that always makes this disease quite a challenge to deal with, because I think whatever we do, inevitably we will get the occasional foal where unfortunately this still happens. I mentioned duodenal disease separately because I think generally you'll see much more profound clinical signs with that. So the foals that genuinely have duodenal disease, so that's a foal that has perhaps ulceration in the duodenum, which can then progress to fibrosis and scarring and narrowing of the duodenum. What you will tend to see if you're getting any outflow obstruction in these foals is you will see colic. You'll see a foal that looks really ill thrifty, will genuinely have persistent colic. They're often really dull. They will have a reduced milk intake, reduced feed intake. They're generally losing weight, and they generally will be showing signs of discomfort because they often will have some esophageal reflux. So you'll see hypersalivation, frequent chewing, and the very occasional foal will get spontaneous reflux. So how do we diagnose it? This is the bit I think we'll skip through quite quickly. I mean, the answer is that you really need to do gastroscopy to diagnose it. There's other things talked about in the literature, things like sucrose absorption. I think the reality is that nobody's probably likely to do that these days, and actually gastroscopy is still a fairly simple thing to do in a foal. There's no real difference other than you perhaps need to fast a young foal for less time. I would say that actually in a really young foal, 2 hours fasting is usually enough. I would usually starve a foal for about 6 hours by the time they're a month of age, and maybe 8 to 12 hours by the time they're an older foal. And you can usually get away with some light sedation, an alpha-2 of your choice and a bit of butorphanol. And for the vast majority of foals, if you really want to know if they've got gastric ulcers, and certainly in these sort of foals, are 2 to 3 month old, 4 month old foals, if you've got an unexplained ill thrift, I think it's really useful to make that diagnosis. The only thing I would say about this is obviously if you have a foal that's really teetering on the brink of a high stress crisis, then actually obviously by imposing fasting on this foal, you are going to increase that foal's stress. They find muzzling quite stressful, you're reducing the milk intake, you're going to have some negative effects. So there would be some indications to say in certain situations that actually you're going to have to treat the foal presumptively, and that you don't think gastroscopy is the best option. And that certainly can be the right thing in some situations. If you have a foal that has delayed gastric emptying, it can also be quite difficult to empty the stomach adequately to scope them. And if you're really trying to evaluate the duodenum, then you obviously need to have the stomach reasonably empty. And again, that can be quite challenging. So, once you get in, you do exactly the same as an adult horse. Make sure you use a gag so you don't crunch your scope. And I would use exactly the same grading system that you'd use in an adult horse. I don't think there's any reason to do anything different, so just skim through that. These are just some examples of the sorts of glandular lesions that we would see. And again, if you can get into the duodenum, it's definitely worth doing. If you have a foal where they have mild duodenal ulcers, you will identify them. It's actually much more rewarding. If you can get in, you're much more likely to see something in a foal than you would do in an adult horse, where actually, let's be honest, the duodenum is often not that interesting. So if you can, then I would get in. If you're finding that there's so much inflammation around the pylorus and you're finding it difficult to get in, then I absolutely would not push this. So you don't want to be, pushing away with a scope in a already really inflamed environment. So see what you can see, and you will, take as much information from that as you can. These is obviously a post-mortem picture, but obviously have a good look at the esophagus too. This is a foal that had a delayed gastric emptying and was having gastric reflux, and this will give you those really horrible esophageal linear erosions that you can see here. I'll just show you this video. This is a video that actually Peter Morrissey from Rood and Riddle had lent to me, but just to show you how extensive the ulceration can be in some of these foals. This was a really quite young foal that had really severe systemic disease, and you can see that this foal's had almost complete loss of the squamous mucosa. So you can get really severe signs in these foals, and especially if they have, like I said, had this multi-systemic disease. And then this is just to show you a bit more about the duodenal problems. So it also, you can have duodenal lesions really close to the pylorus, but they also can be further down. And depending on how far down they are, will obviously impact how easy it is to visualize the problem, but also the amount of outflow obstruction that you will have. And this is just an example of a foal that obviously had really severe duodenal disease. And the absolute end result of that, and the absolute worst case scenario, is that you can get pyloric stenosis. This is a foal that's basically got complete pyloric stenosis. But this obviously is an extreme example of what can happen if you're really getting severe scarring of the pyloric region. So scoping, I think everyone would be quite au fait with. Most people would have scopes and would use that routinely. What other things are useful? I think really, if you're trying to answer the question about whether ulcers are present, you probably only need gastroscopy. But actually, what is useful to try and put it into the context of the whole foal and why it's happened and what's the driving factors, you do need to have quite a good understanding of what the foal's primary disease or pathology is. So that would be, a really good physical examination, consideration of the foal's other factors, other diseases, other, perhaps orthopedic challenges. And you may need some other tests to rule out disease. Like we said already, that foals with enteritis are a real risk for getting gastric ulcers, and you may need to do some tests to understand what's happening with the intestinal disease in this foal. For that reason, I think abdominal ultrasound is very useful. Even if it doesn't give you a diagnosis of gastric ulcers, it will give you a good idea about the general health of the intestinal tract. So we'll be looking, to see if there's any evidence of inflammation from previous enteritis, where there's active inflammation. And we will obviously be able to look at the size of the stomach and visualize some of the duodenum. So these are just some images. This is a foal, again, that's got a severe outflow obstruction. So this is a foal that was just presented for being really dull with mild colic. And you can see this foal's got a huge stomach full of gastric fluid. In the same foal, on the other image, you can see a picture of the duodenum, which you can see is definitely thickened. And so this information is really going to take you a lot further in terms of understanding the severity of the foal's disease and also the implications of it. This is another foal just show you talking about how sometimes the duodenal disease is a bit more distal than you might think. This obviously is a duodenum up by the kidney, and you can see that in this foal the disease was actually quite distal, and so with the endoscope you couldn't really visualize the true extent of the duodenal disease, but on ultrasound a bit more caudally you could visualize that the duodenum looked really abnormal and was becoming kind of quite fibrotic. Contrast radiography can just be useful just occasionally. It's not a mainstream thing, but just in these foals where you're trying to understand, do they really have gastric outflow obstruction? So if you have a foal that's refluxing, you don't need to do this because the stomach is already not emptying. But this can be occasionally useful in one of those foals that's in that slight middle ground where you're suspecting that they've got delayed outflow, but not completely obstructed. It's quite easy to do. You just tube them with some barium via nasogastric tube, and then you have to radiograph them every 15 minutes to start with, and then a bit, less frequently if it goes on. And really what you're looking for in a normal foal is that the contrast should go into small intestine in less than half an hour. So this is an example of a foal that, was having some gastric outflow, but it was delayed. And so this can be useful just to understand a bit about the function in some of these foals. So we'll move on to talk about treatment. And again, we're not talking about different drugs to what we'd use in an adult horse. We're still talking about the same collection of medications that we would use, but we perhaps just want to use them sometimes in a slightly different way or at slightly different times. So again, we've got things like the acid suppressive drugs, so the proton pump inhibitors, which are obviously inhibiting acid production, but we also have the other drugs, things like misoprostol, which are encouraging prostaglandin production. So we think about medication, the mainstay of treatment actually is still going to be omeprazole. So obviously, omeprazole is our sort of first generation proton pump inhibitor, and actually you can use it at the standard adult dose, so 4 mg per kg. Obviously, using one of the enteric coated formulas, depending on where you are in the world, but ensuring that you have one that is appropriately formulated, and you can then use that 4 mg per kg once a day. And actually, there's a whole wealth of studies actually looking at the effect of omeprazole on gastric pH and gastric ulcer in foals. This is the other half of that graph I showed you at the beginning. And you can see that actually in healthy foals, it's a really good acid suppressor. You know, these foals are having acid suppression for 22 hours after a single dose. And that's quite a consistent finding in a healthy foal or a foal that doesn't have really severe disease. You're actually getting generally a pretty reliable response to omeprazole. If you look at sick foals, so this is using omeprazole in ill foals, you'll see you certainly get much more variation. Some of that is again because you're looking at some of these, the starting pH in these ill foals was already alkaline. So you can't expect a drug to, to make much difference if you already had an alkaline stomach. But the take home is it's still effective. You're still getting acid suppression in most foals, but you are getting a bit more variability in foals that are really ill. And just to skim through these, but just to sort of reassure you that actually there's some, quite good studies from the beginning of time of omeprazole showing that actually omeprazole does work. So these studies included ulcers in foals and adult horses, and again the outcomes are good. Omeprazole is a good drug in foals; it usually is pretty effective. What about other options? So obviously, an adult horse, we might use injectable omeprazole. That's not been specifically studied in a foal. It you would suspect that it would have a fairly similar action. I certainly wouldn't use it in a baby foal, but in an older foal, it might be appropriate if you have a foal where you cannot use oral medication. Perhaps some of those foals that are having severe gastroduodenal disease where you're not sure about the absorption. But you do obviously want to be really careful about the risk of injection reactions. But this could be an option in some foals if you cannot use a normal oral route. And then obviously we will sometimes in adult horses use esomeprazole. So there's absolutely no studies looking at esomeprazole in foals. So I don't know if it's absorbed. You would assume actually because of the way the drug works that it's likely to be effective and maybe even slightly more effective than omeprazole, but we don't have that information. Where esomeprazole is really useful is that you can also use it intravenously. So again, if you have a foal, perhaps one of these foals that's really ill where they're having severe outflow obstruction, they cannot tolerate oral meds, you can use this intravenously and that can be quite effective. So the next drug that we think about is sucralfate. This obviously is a drug that's a mucosal adherent, and what we're aiming for is this to form a viscous gel over the ulcers. And beyond that, we're also hoping that it will promote prostaglandin production, mucus, all those local factors that we talked about, that helping to promote that healthy local response in the mucosa. We'd use it again at standard dose. You can do it 20 mg per kg, 2 to 4 times a day. There's not really great studies looking at the efficacy. This is just 2 studies I show you here, sorry. So the first one didn't really show any positive effect. So not, take from that what you will. This second really old study was looking at sucralfate and a drug that we don't even get anymore in toxication, and actually showing that sucralfate actually did have a pretty good protective effect against non-steroidal toxicity. So I think that the evidence isn't particularly strong, but clinically it seems to give a good response in foals. Certainly in foals that have any esophageal ulceration or severe duodenal ulceration, you often will see some clinical benefit from using it. Misoprostol is a final drug that we will use. Again, there's really no studies looking at the use specifically in foals. Again, we know it's a prostaglandin analog, so we're aiming to promote that mucosal blood flow. And especially when we're thinking about the foals where we're worried about perfusion, perhaps these foals that have really severe GI disease, we're worried about trying to promote that intestinal, gastrointestinal perfusion, encourage repair of the epithelium. This is a drug that, logically makes sense to use. It possibly has some mild acid suppressive effect and possibly anti-inflammatory. So again, we don't have much evidence for its use in foals. We would use it routinely in foals if we have a suspicion of any of these reasons. We would use it at the standard adult dose. Like I said, I don't know if that's actually the appropriate dose in a foal, but clinically it would appear to have benefit, and certainly I haven't observed many side effects using it. The other time that you can use this, obviously, is if you do have a foal where you're having to use a lot of non-steroidals. This would be the obvious drug to use to try and limit some of those side effects, because you are providing, you use a prostaglandin inhibitor, so this will help reduce some of the side effects. So, perhaps if you have a foal that has really severe intestinal disease, orthopedic disease, where you cannot get away from the use of non-steroidals, then using misoprostol, there is some logic to using it in that situation. If we then just consider that final subset of foals, that those foals that have delayed gastric emptying, how do we treat them? Do we treat them differently? Well, the answer to that is that they are quite challenged to treat depending on the degree of obstruction. Some of these foals, when they have acute severe ulceration, will have quite a lot of soft tissue swelling, and they'll have a sort of functional obstruction. And as that heals over a couple of days and the inflammation resolves, we'll find that the actual obstruction is not that bad. That's obviously in quite severe contrast to the foals where they've developed fibrosis or real narrowing of that outflow. And that isn't going to change with time. But certainly if we're suspecting that there's a good functional component, then these foals will often respond to intensive care. So, we're supporting them with, nutrition, fluids, using prokinetic drugs, absorbent drugs, mucosal protectants. And in the foals that are going to respond to medical treatment, I would say you would be expecting to see a significant improvement in a couple of days. If you're seeing no change in 2 to 3 days, I'd say you're very unlikely to get an improvement just with medical treatment. And unfortunately, if you have this really severe outflow obstruction, then the only option is to do a gastric bypass. The outcomes of that, in my experience, haven't been brilliant. The reported success rate is about 50% return to racing and thoroughbreds. It's one of those procedures that either goes really well, the foals seem to cope really well with the bypass, or they really don't. So in my experience, it's a real all or nothing phenomenon. But if you have a foal with a severe outflow obstruction, this is the only option to save them. So just to finish, we'll just talk a little bit about prevention. And obviously that should always really be our focus if we possibly can, trying to prevent disease in the first place. And, particularly this peracute gastric rupture if we possibly can. So the main thing, if we're thinking about the baby foals, is really trying to maximize perfusion. So this obviously is a foal that's got really severe systemic disease. And so, with this foal, you can see how many pumps we've got out. We've obviously got pressors and inotropes and all sorts of things. And we're really trying in these foals, rather than supplying gastric protectant drugs, we're trying to maximize perfusion to the gastrointestinal tract. And that's obviously also relevant when we think about foals which have things like diarrhea. We're really trying to maximize perfusion because that will have a positive impact on gastric function. So even perhaps in foals that have really severe acute diarrhea, focusing on giving them adequate fluid boluses to maintain their circulation, is something that you should focus on in terms of the whole picture. Milk ingestion, we've already said, is really important. And, we when we understand the real importance of that alkalizing effect, really doing everything that we can do to promote maximum milk ingestion as much as we can is important. So this is an example of a foal that's obviously got quite severe carpal contracture, is not able to nurse the mare without help, using an indwelling nasogastric tube to make sure this foal is having adequate milk production. They're the really simple things that we can do. And it might be, other ways of making the foal more comfortable to promote good nursing. That's really important in terms of the prevention of the disease. And then we talk about sort of intestinal support in general. And again, this comes back to my point about the fact gastric ulcers being so much more prevalent in foals with intestinal disease. So when we're dealing with foals with diarrhea, we really want to, as much as we can, try and promote the quickest return to normal intestinal health that we can. And so that might be some of the drugs we've talked about, things like sucralfate, misoprostol, but actually it's also looking at the foal's overall gut health. So, this is where all these Hestobard products really come into their own. We're thinking about trying to promote normal microbial function, trying to promote normal gut function. And this is the time where these sorts of things are helpful. Also things like trying to reduce the severity of diarrhea. So I didn't put it on here, but things like smectazorb, where you're trying to reduce the severity of diarrhea as quickly as possible. And then avoidance of stress is really important. And again, that can be quite challenging, but it's looking at things like social groupings of foals, trying to avoid, mixing up foals into different groups as much as possible, trying to keep them, maximizing turnout, minimizing, stabling, minimizing stressful events, things like foals that find the farrier really stressful. So doing everything that's in our power to try and keep these foals in a stress-free environment as possible. And that obviously follows on to weaning, which we've talked a bit about already. But again, it's really thinking about our weaning practices and really trying to reduce the stress. So keeping these foals in stable groups, um, you know, trying to make this as stress-free as possible. There's actually some great studies now looking at age of weaning too, and showing there's a real positive benefit to later weaning. So something as simple as perhaps pushing weaning to after 6 months. You know, a lot of thoroughbreds would historically have been weaned before 6 months, but actually there's some quite good evidence now showing that thoroughbreds weaned after 6 months will go on to perform better in later life. But also, speaking to stud managers, they observe that actually if you can push these foals a bit later, they will find the weaning process, excuse me, a lot less stressful. And so again, you know, these are simple things that we can do which can have a good role in prevention. Obviously, we talked about non-steroidals, so avoiding using them as much as possible. You know, there will be times when we are forced to use non-steroidals. You know, if we think about all the different diseases that we contend with, you know, sometimes foals with severe colic or severe musculoskeletal problems, you know, sometimes we will need to use these drugs. So, but it's trying to think about using them carefully. So using them for the shortest period, using them perhaps in combination with other drugs so we can minimize the dose. And if we possibly can, trying to avoid the drugs that we know have the most ulcer inducing effects. So we've talked about butylphenixin as having quite a strong tendency to induce ulcers. Drugs like meloxicam, which are more COX-2 selective, although we all know that's not the be all and end all, but these drugs seem to have less effects. And looking at the pharmacokinetic studies from these drugs, they didn't appear to induce significant ulcers. So perhaps using these drugs, if you can, in preference, if you have to use non-steroidals, and again, thinking about, you know, using things like misoprostol if you're using non-steroidals for a prolonged period of time. So just the final sort of couple of comments about prevention is using drugs for prophylaxis. And obviously when we're thinking about the specific foals, it makes logical sense. If you have a foal that you're really worried about, really highly stressed at weaning, it would make sense to give them some medication for prophylaxis. The only problem is the jury's slightly out on the effectiveness of this. So in this post-mortem study, they found actually there was no reduced incidence of gastric ulcers in foals that were undergoing gastric ulcer prophylaxis to foals that were receiving medication. And just another couple of things to sort of think about is that, especially in these young foals, there's some evidence that suppressing acid has a negative impact on survival. And that may be, like I said already, that some of these foals are not able to generate enough acid, and that is the reason. You know, it's a reflection of gastric function rather than the pH. But actually, it may also be that this alkaline pH is associated with bacterial colonization. So it's just saying that, you know, sometimes, you know, using these drugs is not always the right thing to do. This is quite old study now that we were involved in, but looking again at whether or not that using omeprazole increased the risk of diarrhea, and there was a mild increase in diarrhea. So it may also be that we don't fully understand all the side effects of these drugs. And so there are reasons to say, actually, if we don't need them, we shouldn't use them. So just to finish with a really brief case example, I think this is just to give you an example of how I perceive, for the majority of us, this is how ulcers would present in practice and the sort of reality of it. This is a 3-month-old foal that had diarrhea at 2 months of age, which we know is really common. You know, most of the foals that we deal with will have had transient diarrhea at some point. You know, this foal had sort of standard, you know, quick onset symptomatic treatment, recovered quite quickly. As part of that, this foal did have some omeprazole just for a week, but, you know, it wasn't that this wasn't considered. But at 3 months of age, this foal is flagged up. Again, not because it's looking terrible, but because it's not keeping up with its friends. You know, it's starting to show a reduced weight gain. It's slightly dull. And when we look at this foal and run some bloods, we see it's just got that low-grade inflammation. And then when we scan the abdomen again, we're just seeing mild signs that there's possibly some residual mild intestinal inflammation. And these are the sorts of foals that if you scope them, this is the stomach from that foal, you see this foal's actually got really fairly extensive squamous ulceration. This foal was then treated with a month of omeprazole sucralfate, responded really well, was rescoped actually, which if you can encourage people to do is useful to understand. It's not always possible, I know. And then this foal, you know, made a good recovery and carried on with its friends. So my summary of this, I think if you're looking at these really young foals, you know, really remember how different that physiology is. You know, you need to think about this as a different subset of foals. So there's older foals. Your main focus should be on optimizing perfusion. So that's all the things you can do to optimize, circulation, think about optimizing perfusion to the gut. If you possibly can avoid acid suppression, you should do that, especially in that early period. We also don't understand the effects of acid. Acid may have some role in absorption of cholesterol antibodies. Encourage milk feeding as much as possible. That should always be a real focus. And if you really feel you need medication in this group of foals, then possibly using sucralfate is the best drug to select. And then as these foals get older, you can think about them much more as adults, but the real focus should be on trying to minimize risk factors and stress, looking at diets critically, encouraging lower starch diets, but not being afraid to treat foals that are in high risk groups. So foals that are under high stress for whatever reason, disease, events, not being afraid to treat them, not being afraid to treat foals that are having non-steroidal treatment, and certainly this big subset of foals which have diarrhea or gastrointestinal disease. They would be foals that I would encourage you to think about treating. And I think keeping it simple for me, actually, still the best evidence is that just using oral omeprazole is a good first line therapy. If you have foals that really have clinical signs of gastric ulcers, I would definitely use sucralfate as well. To use those two drugs in combination. And there possibly is a role, especially in these foals with concurrent intestinal disease, for using misoprostol. So just to wrap it up, and then we'll have time for a few questions. I think, gastric ulcers are really common. Your ability to treat foals will be really enhanced by understanding the risk factors at different times. Think about whether you really need to use anti-ulcer medications, but definitely don't be afraid to treat if indicated. I think there's a lot of times where actually, using gastroprotectants in these foals is the right thing to do. And that's it. Thank you very much. I don't know if I
Thank you, Emily.
stop sharing.
That was absolutely excellent. Thank you very much indeed. There is quite a number of questions that have come through.
Okay.
So some of them have been obviously asked earlier in the presentation, so you may have subsequently answered some, but we'll run through them. And if anybody's got any more questions, then they can put them on. We'll do our best to answer them. So the first one is, does omeprazole have to be administered on an empty stomach? And they want to know both for foals and adults.
So in adults, the answer is there's really good evidence that you'll get much better absorption on an empty stomach. So the advice would be to always feed it in the morning as the first thing, and that will improve, half an hour before feeding, that will improve absorption. People obviously then always really worry about the timing, providing horses with their forage overnight. The vast majority of horses will have a period of fasting naturally, and that's sort of from midnight onwards. So actually just generally giving the drug in the morning is the right answer, and then trying to give a period of delay before you give any other feed. I think in foals it's a bit more difficult. In those young foals, when they're having just milk, it probably doesn't make any difference at all, because you're not getting that big fiber mat. As the foals get older, you're getting more fiber mat. You probably are getting some reduction in absorption. I don't think anyone's done the study to know. So I'd say the older the foal, the more absorption you will get if the stomach is empty. But what I would never do in a foal is I would never worry about starving the foal to do that. So probably giving it a time before you're giving extra feed would be the sensible thing to do.
That's great. Thank you. The next one is, how would you reduce omeprazole treatment once the ulcers have got better?
Another great question. So we don't really know if you get rebound acid production in foals. I assume you do, because it would make sense. So if you've had a foal that you've treated for, perhaps a month, and you've rescoped it and it looks good, I would do exactly what I would do in an adult horse. I would wean it off over a period, perhaps a week, where you're giving it a decreasing dose, with the argument that you're then trying to stop that rebound acid production. So just, half the dose, then give a quarter of the dose, which obviously can be a bit more difficult in foals, but I would try and do the same thing.
Brilliant. Thank you. This next one you may have covered off before, but do you ever use misoprostol as well as omeprazole, or always one or the other?
The answer is, there's quite a few. There's that argument that you shouldn't use the two together, and that if you're suppressing acid, misoprostol won't work. The answer is I use the two together all the time, and I don't perceive there really being a problem with it. So I think it's fine to use them both together.
Brilliant. Thank you. The next question is, does omeprazole increase the susceptibility of foals to infections by lowering the gastric pH?
So great question. That's just touched on that at the very end. So in humans, there is that suggestion. And certainly if you think about things like human intensive care, people getting things like Clostridial difficile infections, there is some argument, especially in a hospital environment, that you might be more likely to get a hospital-acquired C. diff infection if you haven't got that acid. That acid is potentially protective to bacteria coming through. So I think there is a theoretical risk to that. I think actually in reality it's probably not that much of a concern. And that was what that large sort of multi-center study was aiming to look at, actually was aiming to look at whether or not acid suppression was associated with an increased risk of diarrhea. And there was a very slight increased risk of diarrhea, but I think actually it's probably not something to spend too much time worrying about.
Okay, that's brilliant. Thanks, Emily. These are good questions and great answers. The next one is it possible for a foal to drink milk from the mare with a nasogastric tube in place, or exists the risk of aspiration?
Yeah, absolutely, definitely possible. And the narrower the tube you use, the less. If you're using a really fat tube, there's a bigger risk of aspiration. But in those really small ones, we use the Milo ones, but there are other brands. They're only maybe 5 millimeters. You can leave them in place. The foal can drink fine, and it really means you can then top up the milk. The foal can still nurse, and you can top up with additional milk if you need to.
Excellent. And one of the questions, which I think again you did touch on about the weaning, is that causing gastric ulcers? And if so, what steps can we take during that weaning period? As you
Yeah,
mentioned
great.
about doing the weaning at 6 months.
Yeah, so I think definitely pushing the weaning as late as you can. There's definitely that would be step one if you possibly can. So the latest, as late as is possible in your situation. I understand there's pressures of, you know, different things, but pushing it as late as possible. And then it's just everything else, trying to reduce the stress. So trying to get the foals in nice stable groups first. I think diet is really important. So I think really trying not to push too much starch at this point makes a lot of logical sense. You can actually supply a lot of short fiber feeds, which will provide plenty of energy if you need extra energy, but really trying to avoid that big starch push. I think that's probably the other really important thing.
That's great. And we've got another handful of questions which I think we can get through. One of them here is, are you using misoprostol in foals with orthopedic disease and gastric ulceration, or did you mean that could be used in a preventative role?
So ask me that one more time, Bruce. I missed the
Sorry.
beginning.
Are you using misoprostol in foals with orthopedic disease and gastric ulceration, or did you mean it could be used in a preventative role?
Yeah, so I think if you're having a foal that you're having to use a lot of non-steroidals, having some prevention is sensible. And you can use omeprazole, that's fine. There's no contrasting studies, but you can also use misoprostol because it actually logically makes more sense. You're providing a prostaglandin analog. So I would consider using it in prevention if you're having a foal where you've got to use a lot of non-steroidals.
Great. If you've got a foal that needs stronger non-steroidals, such as flunixin or bute, would you administer stomach protection directly or monitor the foal closely?
If I had a foal where I could not avoid, I mean, I hardly ever would use bute. But if I had to use Clinician, which sometimes you do, then I would actually I would use something at the same time, either omeprazole or, yeah, I mean, there's different arguments, but yeah, personally, I would use some gastroprotectants in that foal.
Very good, thank you. Here's a question from a vet in Germany. So, according to the package insert, Gastrogard is not recommended for animals under 4 weeks old in Germany. And how do you work with that? How do you handle that?
Yes, I can't answer for Germany because I don't know. I suspect that your rules may be stricter than ours. In the UK, actually, I shouldn't really say this, should I? Will be recorded, but we're fairly casual about using things off license, so we would be able to use that through the Cascade in the UK. And certainly, I don't know about the logistics of the legalities in Germany, but certainly in the UK, I wouldn't have any concerns about using it in a foal after. I'd try and avoid it in those first few days, maybe a week, but after that, I wouldn't have any worries about it.
Thank you very much. One of them here, it's interesting there is an increased risk with rotavirus. How about other pathogens such as Clostridial diarrhea?
Yeah, great question. I think, like I said, if you're having any foals, particularly with severe diarrhea, and obviously some of the clostridial diarrheas are the most severe. So I think by nature of the fact that you're having severe diarrhea, you can have it with any of the pathogens that we deal with. Um, so yes, absolutely, definitely can. I think there is something about the way the rotavirus infects the villi in the duodenum, which gives this predisposition to duodenal disease, which I think is a bit rotavirus specific, but certainly, absolutely, with any form of especially severe diarrhea, you can get ulcers.
Great, thanks, Emily. Are you okay for a couple more?
Yeah, they look like getting trickier. So yeah, hit me with
Okay,
it.
okay. One of them is there a higher risk for the development of gastric ulcers in foals fed with milk formula?
God, that's a great question. Answer is I don't know. Um, don't know is the answer. I would have a tendency to suspect that probably there may be a slightly in as much as if you're feeding a full milk replacer, inherently there's something that's not optimal in its life, isn't it? Either it doesn't have a mother or its mother's not making enough milk. It's definitely less digestible. So my suspicion would be say yes, probably. But actually, I don't know if there's any studies, and it probably depends a bit on the individual situation. If you've got a perfectly healthy, really, well foal that's been fed milk replacer from a few weeks of age, it's probably less risk, I would say. But inherently, I would think probably there is a bit more riskier.
Thanks, Emily. And so one of the last ones we'll do here, and there's some more questions have come in, which will answer after the webinar because the more that get asked, the more that come in, which is great. Is can we use vitamin A and antihistamines while treating the gastric ulcers?
Great question. Vitamin A, I've got no idea. So I don't think I've ever used that in a foal. Antihistamines, I can't see any reason why you couldn't use that with gastric ulcers. Again, that's not something we'd use that commonly. The vitamin A, I'd have to check. Sorry, don't know.
No, that's quite all right. We can get back to some of these other questions afterwards as well because there is some great questions, and we seriously appreciate everybody coming on because it's been a phenomenal presentation. So thank you very much, Emily, and all the best with your ride. Do you want to say anything about that to the attendees?
Oh, I didn't put the slide in. Just if anybody wants to follow us, I am going across the Andes on horseback on the 22nd of February with one of my friends who's disabled. She wants to be the first disabled woman to ride across the Andes. So get on social media, look at Equine Power Adventure, and you'll find all the stuff there to follow us. So yeah, if you want to have a different sort of adventure, follow us on there. Yeah, thanks, Bruce.
No problem. No, all the best for it. It's absolutely amazing, and thank you very much for your webinar tonight.
You're very welcome.
Good.
All
See you
right, thank you
later.
so much. Thanks, then. Take
Thank
care.
you. Yeah, goodbye.